Hello everyone. So today's topic is cardiomyopathy. We have the classification of cardiomyopathy based on phenotype, dilated cardiomyopathy, hypertrophic, restrictive, arrhythmogenic right ventricular, and unclassified. This classification we all know. The classification within the unclassified, we have three most important: Takotsubo, left ventricular non-compaction cardiomyopathy, LVNC, and we have IVNC. So left ventricular non-compaction cardiomyopathy, isolated ventricular non-compaction cardiomyopathy. In IVNC, it is the right ventricle that is affected. In LVNC, it is the left ventricle that is affected. So left ventricular non-compaction cardiomyopathy, isolated ventricular non-compaction cardiomyopathy, and Takotsubo is stress-induced cardiomyopathy, also known as broken heart syndrome. So we'll discuss DCM and HCM in this video. In the next video, we'll discuss RCM, ARVC, and other cardiomyopathies. So DCM, see in DCM we have enlarged dilated ventricle. See, enlarged dilated ventricle with decreased ejection fraction, which is not explained by CAD or valvular heart disease or abnormal loading conditions. If there is coronary disease or valvular heart disease or abnormal loading condition, then it is not a primary DCM, it is a secondary DCM. In secondary DCM, we have a primary cause which leads to DCM. So DCM, which we discuss as a cardiomyopathy, it is a primary condition which is an enlarged dilated left ventricle with decreased ejection fraction, which is not due to CAD, coronary artery disease, or other conditions like valvular heart disease or abnormal loading conditions. And etiology mein, what are the causes? Most common cause is idiopathic of DCM. Second most common cause is genetics. In genetics, the most common cause is the TTN gene mutation, which encodes for the titin protein. Titin protein, TTN gene present in chromosome 2. Very simple to remember. Remember 2 for 2, chromosome 2 and 2 for titin. So chromosome 2, TTN gene, titin mutation. And titin protein में which mutation is most common? It is the truncating variant, TTN-TV. Titin protein का TTN gene का truncating variants are the most common type of mutation that we see in this case. And other causes are alcohol and viral and PPCM, that is peripartum cardiomyopathy. Alcohol we all know. Viral cause में we have Coxsackie, the most number one cause, Coxsackie, adeno and HIV. Coxsackie, adeno and HIV. PPCM, when it happens from 1 month to delivery after 5 months of delivery. So from 1 month of delivery up and after 5 months of delivery, within this time frame, you develop PPCM. Okay, so the ejection fraction decreases less than 45%. Okay, and the causes are genetic, autoimmune, and oxidative stress. All these three together causes the peripartum cardiomyopathy. Now, pathophysiology of DCM, we have thin stretched walls. Okay, thin stretched walls. In these thin stretched walls, you see we see all the three components, that is myocyte hypertrophy, myocyte atrophy, and fibrosis. So hypertrophy, atrophy, and fibrosis, all three. The fibrosis is both interstitial and replacement fibrosis, which is detected by the Mason trichome stain, which has three stains: hematoxylin for the nucleus, acid fuchs chain for the cytoplasm, aniline blue for the collagen. Hematoxylin, acid fuchs chain, aniline blue, three stains. Mason trichome stain. Electron microscopy will show you sarcomeric disarray because the titin protein is mutated, so it will be sarcomeric disarray. And hematoxylin leucine stains, you see the elongated myocytes, myocyte atrophy, and hyperchromatic nuclei. This is the normal picture of a cardiac tissue. You see the compactness, how compactly they are together, these cells. And this is a case of DCM. See how sparse the cells are. There is atrophy, there is also elongation, and there is this collagen deposition in these areas. So DCM, what is the treatment? The pathophysiology is neurohormonal blockade. So you have to give neuronal block and hormonal block. Hormonal RAAS system block, renin angiotensin aldosterone system block, ACE inhibitor ARB, and neuronal means sympathetic nervous system activation. For that you have to give beta blocker to block the sympathetic nervous system. So neurohormonal blockade, that is the treatment for DCM. And to prevent the arrhythmias you have ICD and CRT. Okay, ICD implantable cardioverter defibrillator, it is to prevent the sudden cardiac death, and CRT, that is cardiac resynchronization therapy. This is given when the patient has a wide QRS complex which is even more than 150 millisecond. Normally QRS complex is widened when it is more than 120 millisecond. But when it is more than 150 millisecond, we say it is very wide QRS complex. This is seen in bundle branch block, both right and left. But right bundle branch block does not cause any problem. Left bundle branch block में आपको क्या होगा, your medications won't work for heart failure, because left bundle branch block as such doesn't cause any symptom. But when there is heart failure, it will aggravate the heart failure, and this heart failure will not respond to the treatment. So for that, you have to give cardiac resynchronization therapy to correct the left bundle branch block, and ICD to prevent sudden cardiac death. Now this is for arrhythmia. Now what happens when the heart failure continues to progress? See, heart failure when it continues to progress due to dilated cardiomyopathy, to manage that you have to give ventricular assist device when it is no more working, right? So left ventricle is no more working properly, you have to give ventricular assist device. When this fails, finally you have to give the patient heart transplant. Now coming to hypertrophic cardiomyopathy, it is mostly genetic and very rarely it is non-genetic. Hypertrophic cardiomyopathy, it is autosomal dominant just like your DCM. The mutations are beta chain of myosin heavy chain and myosin binding protein C, MYBPC, myosin binding protein C, and beta chain of myosin heavy chain. So we see both hypertrophy as well as fibrosis, just like DCM also. But in DCM there is also atrophy, but there is no atrophy over here. And in DCM atrophy is more prevalent, and fibrosis you see in between atrophy. In HCM, 70% of the patients develop obstructive pattern, the left ventricular outflow tract obstruction. Okay, so LVOT obstruction, that leads to hypertrophic obstructive cardiomyopathy. 70% of the patients with HCM become HOCM. Now this myocyte hypertrophy, that is the underlying pathophysiology of HCM. This causes diastolic dysfunction. That means the heart is not able to relax. Because the left ventricle is not able to relax, the left ventricular end diastolic pressure is much high. This does not allow the blood to go from the left atrium to the left ventricle. Left ventricular end diastolic pressure is very high. This LVEDP increase will cause increase in the left atrial blood accumulation. This will cause pulmonary congestion, retrograde backflow, right? Retrograde flow will cause pulmonary congestion. Now coming to myocardial hypertrophy that we see in this condition, the most prominent hypertrophy is seen in the interventricular septum. The interventricular septum is thickened more than the free wall of the left ventricle, which causes asymmetrical hypertrophy. This asymmetrical hypertrophy leads to asymmetrical septal hypertrophy also. With septa, it is IV septa. And also there is also systolic anterior motion of the mitral valve. The mitral valve anterior leaflet. So you have two leaflets of the mitral valve, one anterior leaflet and one posterior leaflet. This anterior leaflet will be having systolic motion and systolic anterior motion. This systolic anterior motion of the septal, this systolic anterior motion of the anterior leaflet of the mitral valve will cause further obstruction and mitral regurgitation. So SAM is pathognomic in case of your HOCM. So pathognomic almost HOCM में होता है almost, और बाकी कहीं दिखता नहीं, systolic anterior motion of mitral valve. Then the murmur of the HOCM. See, the murmur on HOCM is the unique murmur which increases with decreasing the preload. In all the conditions where you see increase in the loudness of murmur is with increasing the preload. By increasing the preload, your murmur sound also increases. But HOCM murmur decreases with increasing the preload. So for that, what you have to do, you have to decrease the preload. And what happens and how you decrease the preload? With Valsalva. Valsalva में क्या होगा? Valsalva में आपका प्रेशर बढ़ जाएगा, ठीक है, एब्डोमिनल प्रेशर ये सब बढ़ जाएगा, तो प्रीलोड घट जाएगा आपका. ओके, प्रीलोड घट गया, घट जाने से आपका ये साउंड जो है ज़्यादा हार्श और ज़्यादा सुनाई देगा. द मर्मर ऑफ एलिवेटिव मर्मर इज ए सिस्टोलिक मर्मर, राइट? इट्स ए सिस्टोलिक मर्मर. एंड लास्टली यू हैव टू रिमेंबर दैट हाउ टू डिक्रीज द प्रीलोड, हाउ टू इंक्रीज द प्रीलोड. So decreasing the preload is by Valsalva, increasing the preload by squatting. And what will happen with preload, you have to understand and you can answer accordingly. Increasing the preload will decrease the murmur. Decreasing the preload will increase the murmur of HOCM only. All other murmurs are increased with increasing the preload and decreased with decreasing the preload. So in squatting, your preload increases. This will cause decrease in the HOCM murmur and increase in the other kind of murmurs. So treatment with HCM, beta blocker. So the type of beta blocker that we use, not important. But the choice is first of all beta blocker in HCM also. Hypertrophic cardiomyopathy, the choice of treatment first line drug is beta blocker. You remember what was the drug of choice? What was the drug that was using in DCM? We were using beta blocker along with the RAS inhibitors. But here in HCM, we are not using RAS inhibitors. We are using beta blocker. And we are using non-DHP calcium channel blockers. Why non-DHP? Why non-dihydropyridine calcium channel blockers? Because the calcium channel blockers which are dihydropyridine, DHP जो CCBs होते हैं, they are mainly affecting in the vascular smooth muscle. But the non-DHP CCB, they are acting in the cardiac. And within the non-DHP CCB, we have two drugs, verapamil and diltiazem. Both in the other two, there are again further two categories of non-DHP. And within this, one example is verapamil and other one is diltiazem. The verapamil is more selective for myocardium. Verapamil comes under phenylalkylamine. In short, I am writing phenylalkylamine. And diltiazem comes under benzothiazepines. So phenylalkylamine, benzothiazepine, these are the two category of drugs within the non-dihydropyridine. Verapamil is more selective, which is the phenylalkylamine. Diltiazem is intermediate between the verapamil and the DHP calcium channel blockers. अगर मैं सिर्फ DHP calcium channel blockers की बात करूँ, okay, so amlodipine ये सब जो है, ये nicardipine ये सब, they are the DHP CCB. Okay. And next, for obstructive type HCM, that is for HOCM, use disopyramide. Disopyramide is a class 1A antiarrhythmic. Just a quick recapitulation of the Vaughan Williams classification of the antiarrhythmic drugs. We have class 1, class 2, 3 and 4. Class 1, 2, 3, 4, some block potassium channel, that is a mnemonic. Sodium, beta blocker, potassium channel blocker and calcium channel blocker. Some block potassium channel. So class 1, we have class 1A, 1B and 1C. Class 1A is moderate block of the sodium channel. Class 1B is mild block. Class 1C is strong block. Remember this, it is not mild, moderate, severe. It is moderate, mild and then severe. So moderate, mild, severe. Class 1A, class 1B, class 1C. Sodium channel blockers, membrane stabilizing agents. Class 2, beta blocker. Class 4, calcium channel blockers, non-DHP calcium channel blockers. It has to be non-DHP because it is working on the heart. And class 3 is potassium channel blocker. So sodium potassium is 1 and 3. Beta blocker, calcium channel blocker 2 and 4. Class 5 is miscellaneous. And again, what are the drugs in the class 1A? DQP, you can remember. DQP stands for disopyramide, the drug which we are using in HOCM, quinidine and procainamide. So remember DQP, disopyramide, quinidine, procainamide. In these three, disopyramide is the one that is mostly used. So that is why we are using disopyramide, not quinidine, not procainamide. And class 1B, you have LMP, lidocaine, mexiletine and phenytoin. Lidocaine, mexiletine, phenytoin. Remember, disopyramide, quinidine and procainamide, and lidocaine, mexiletine and phenytoin. And class 1C, you have flecainide and propafenone. Okay, so this is procainamide, this is phenytoin, this is propafenone. Remember, disopyramide, quinidine, procainamide, lidocaine, mexiletine, phenytoin, flecainide and propafenone. So this is class 1A, 1B, 1C. So class 2 you remember, very easy, all the simple drugs, beta blockers में जो सब है. Class 3 फिर से यहाँ पे थोड़ा सा याद रखने में दिक्कत होता है. Remember the mnemonic 8 potassium channel blockers. Okay, A for amiodarone, I for ebutilide, D for dofetilide, S for sotalol. Sotalol is also beta blocker, but beta blocker with potassium channel blocker action. So amiodarone, ebutilide, dofetilide, sotalol. Amiodarone is actually a class 3 drug, but it has actions of all the class 1, 2, 3 and 4. It is a sodium channel blocker, it is a potassium channel blocker, it is a beta blocker, it is a calcium channel blocker, but mostly it is a potassium channel blocker. That is why it is in the class 3, amiodarone. Okay, so it is mostly in the class 3 action, तो इसलिए इसका class 3 में इसको लाया गया है, but it is having actions of all the classes. Okay, amiodarone, ebutilide, dofetilide and sotalol. These are the 4 class 3 category drugs. Finally, the class 4 category drug is your calcium channel blockers, which are non-DHP. You have phenylalkylamine and benzothiazepine, verapamil and diltiazem. Class 5 है miscellaneous drugs. Okay. And recent drugs which is used for HCM, which is in the obstructive variety, like obstructive maybe we're using disopyramide. So for HCM, which is obstructive type, we have come with cardiac myosin inhibitors. These are the newest drugs in 2022. They have been approved by the FDA. So mavacamten and aficamten, these are the two drugs. Camten, you remember from the CANM, that is cardiac myosin inhibitor. So mavacamten, aficamten. Okay, and other then the drugs, we have surgical management. Surgically we can do septal myomectomy or alcoholic ablation of the septum. Okay, and lastly ICD तो देना ही है patient को to prevent sudden cardiac death in this patient, because the most common cause of death in these patients hypertrophic cardiomyopathy में it is sudden cardiac death. So ICD तो देना ही है इन लोगों को. And yes, so we have covered this topic for now. Next we'll discuss the other types of cardiomyopathy.